Okay, now we're going to do Chapter 15, which involves the prenatal diagnostic test. So what are some types of prenatal tests? Well, of course, we have ultrasound, and everybody should already know what ultrasonography is and ultrasound. Doppler ultrasound to assess for blood flow through the umbilical artery. We do an alpha fetoprotein or an AFP screening, which helps to determine fetal age. We do multiple marker screening, which screens for chromosomal anomalies. We have the chronic villus sampling, and then you remember the villi that are on this conceptus that are trying to attach to the decidua, and it can help detect chromosomal, metabolic, or DNA anomalies. And then we have an amniocentesis, and that's just where we analyze the amniotic fluid. And also we can evaluate fetal condition when there is Rh positive sensitivity or sensitized. So basically, there's two types of testing, and we're going to talk about some more in just a minute. But let me back up a minute and say there's two types of testing. One is screening, and one is diagnostic. So screening, we do that to predict the odds or chance that baby has a birth defect. And then diagnostic testing, we see if baby does have it or baby doesn't have it. With ultrasound, we have two types of ultrasound. We have transabdominal, which is the one you're thinking about. They put the gel onto mom's belly, and we use the ultrasound to see the fetus. We also have the transvaginal probe, which is actually placed into the vagina, and we can look and get an idea of what's going on inside the uterus, especially early in the pregnancy. Okay, so these are some more tests, prenatal tests, percutaneous umbilical blood sampling, and this is actually where we take a blood sample from baby's umbilical cord, and we can see, we can do a chromosome evaluation. So antepartum fetal surveillance. So this is a test that we're going to do while mom's pregnant. So we have the non-stress test, which is the NST, and this just tries to determine or determines adequate oxygenation and response of fetal heart to stimulus. We have the vibroacoustic stimulation test. We have the contraction stress test, which is also called the oxytocin challenge test. We have a biophysical profile, or a BPP, and it looks at 5 parameters with the fetus. We can have a modified biophysical profile, and then we can do or have mom do a maternal assessment of fetal movement, which is a kick count that mom does. So ultrasound is safe. It's non-invasive. Usually during the first trimester we would do a transvaginal, and then during second and third trimesters we'll do a transabdominal. So we use it during pregnancy to determine a variety of fetal and placental conditions. It's going to tell us the presence of and the location of the pregnancy, whether or not there's more than one fetus or embryo, the gestational age, and a viability confirmation. So ultrasound is really used to aid in the performance of other tests. And then we talked a little bit about Doppler ultrasound, and that's just to assess blood flow through the umbilical artery. And this is just an example of ultrasound. This is the 3D ultrasound. These are all in your book. So if you want to go back and look at these. So the first one we're going to talk about, the alpha fetoprotein screening. And it's performed on mom's blood or on the amniotic fluid to identify open body wall defects or chromosomal anomalies. And there are 3 markers: the human chorionic gonadotropin, estriol, and inhibin A. Okay, the chorionic villus sampling, and remember the villi are what's on the conceptus that help it to attach to the uterine wall. It can be performed as early as 10 weeks, and it gives us information about chromosomal defects and metabolic abnormalities. So this is just an example, an illustration showing you a transcervical chronic chorionic sampling. And so you can see we have, this is invasive. We actually have to go in through the vagina so that we are able to access fetal blood and fetal tissue. And we use an ultrasound to guide it. So for an amniocentesis, and this is where we just draw out amniotic fluid and we analyze it to see if there's any problems going on. And normally this is indicated for moms who are greater than 35 years old. They have a first-degree family member who has a chromosomal abnormality. To determine the sex, to see if there is if the mom is a maternal carrier of an X-linked disorder, or if you had a previous baby who had some type of abnormality, neural tube defect, or a body wall defect. We also do an amniocentesis if mom has had a lot of spontaneous abortions. If mom has an elevated AFP that they can't figure out what's going on, or mom is RH sensitized. And remember, that's when an RH negative mom has an RH positive baby, and she develops antibodies against that RH positive portion and could cause problems in the next pregnancy. And this is just an example, an illustration of how they do an amniocentesis. They use a large bore needle and a syringe, and they actually go through the abdominal wall into the uterus and just aspirate out some of the amniotic fluid. So the next one is the percutaneous umbilical blood sampling, and this is just where we take fetal blood from the umbilical cord to do some diagnosing or some therapy, and it can help detect blood disorders, acid-base problems, infection, or a fetal genetic disease. So this is an example, and you see we actually have to use an ultrasound to guide the needle so that we're able to get into the umbilical cord at the right place in order to aspirate some blood out. So some other tests that we're going to do during pregnancy is the NST, and this is a non-stress test. We just evaluate fetal heart rates and accelerations with or without fetal movement. So fetal heart rate reactivity with accelerations is a reassuring sign. We talked about this yesterday in class about what was reassuring, and accelerations are reassuring. So reactivity is associated with adequate fetal oxygenation and the intact neural pathways. And fetal heart rate activity reactivity may not develop until 32 weeks in the fetus. So this is done a little bit later. And this is just the example from your book. You see they have marked FM for fetal movement, and you see there is an acceleration associated with the fetal movement in the first one, but in the second one, in B, you see that we have fetal movement, but there is no acceleration with that fetal movement. The CST is used to determine how the fetal heart responds to contractions. That, remember, when we have a contraction going on, baby's being squeezed, umbilical cord's being squeezed, he's not getting blood flow. So this cannot be done if a stimulated uterine contractions are contraindicated. So if mom had had previous spontaneous abortions or she's having trouble, then we can't do this. We can't cause contractions because it could cause her to deliver early. So this is just an example. The top one is negative. You see that baby does not respond or does not have any changes in heart rate when a contraction occurs. So consistent late decelerations in less than or greater than or equal to 50% of contractions, even if contraction frequency is less than 3 to 10 minutes, indicates UPI and fetal compromise during contractions. And so on B, this shows that we do have decelerations occurring, and they're late decelerations. So so that gives us an idea about what's going on, and if we have to do some of those intrauterine resuscitation, such as changing position, or maybe changing the infusion or placement of the TOCO transducer, you know, to try to see if that will help. Alright, so a biophysical profile, and this basically involves the non-stress test, fetal breathing movements, gross fetal movements, fetal tone, and amniotic fluid volume. And the amniotic fluid index is a method to quantify the amount of amniotic fluid visualized by the ultrasound. So here's a little bit about what we were talking about yesterday about acidosis and hypoxia. So late decelerations appear first. That's one of the first signs. And remember, we don't want late, we want early. Accelerations disappear, so we don't have a lot of variability. Fetal breathing movement stops, and then fetal movement stops, and that's a late sign, because once fetal movement stops and we don't have any fetal tone, then the fetus is compromised. So, so that's what we were talking about yesterday with acidosis occurring. So then the maternal assessment of movements, we said these are kick counts. Usually we want at least 10 fetal movements within 12 hours. So what we do is we count a couple of times a day, and we want at least 3 movements in 60 minutes. But remember, this can cause mom to become really obsessive about whether or not baby's kicking enough, because baby may be asleep and they get really upset because baby hasn't moved. So, you know, we have to make sure that mom understands why we're doing this, and that if baby doesn't move, baby could be asleep. That doesn't necessarily indicate a problem. Okay, so of course, if we're going to be doing diagnostic testing on pregnant women, we've got to know, you know, those things like how many times have they been pregnant, how many living children do they have, based in comparison with how many times they've been pregnant, at what gestational age were all of their live children born. Does mom have other healthcare problems? For example, epilepsy, hypertension, diabetes, things like that that could cause problems, and we may need to do more diagnostic testing and making sure nothing's wrong. Does she have any current obstetric problems? Does she have cancer? Has she had problems with conception in the past? And of course, does she have any history of substance abuse, including alcohol and tobacco, since these can cause problems with the fetus? Of course, make sure that you inform your patient what you're going to do and why we're doing it. And if it's a normal routine test, that we reassure her that this is what we do with all pregnant women. You know, it's just a precaution to make sure there's nothing going on, and this is what we're testing for. And if it's a mom who's already had babies before, you know, she may or may not have an understanding of these tests, and she may or may not understand why additional testing may be needed if an anomaly is found. And, you know, how is she responding to the test? Is she very upset? Is she crying? You know, is she taking it well? What do the parents expect of the test? Do they know that they're carriers for a certain type of genetic disease and that there's a possibility that baby could be born with it, because that's why we're doing the test? So you have to take into consideration how mom and significant other are handling these diagnostic tests, and that they are educated to the best of our ability to understand why we're doing this and what we're looking for. Okay, so just a quick question. A BPP includes information regarding all factors except fetal breathing movements, gross fetal movements, amniotic fluid levels, fetal length, and gestational age. And so the correct answer is fetal length and gestational age. All right, this was a really short one. So that's it for our prenatal test. There's plenty of information in your book also about prenatal tests. This is just a quick overview of them. You will need to read in your book in length about what else is involved in these tests. You need to know whether or not they're invasive or not. Risk factors associated with the test if it is invasive. So, all right, I'll see you guys next time.